Emetophobia is an understudied and misunderstood specific phobia. It is characterized by an intense and irrational fear of vomiting, including fear of feeling nauseous, seeing, or hearing another person vomit, or seeing vomit itself. Literature suggests that a combined approach of cognitive behavioral with psychopharmacological interventions may be an effective treatment for emetophobia. The current case study will illustrate evidence-based assessments and the use of exposure therapy treatment for a 22-year-old with a specific fear of vomiting. The patient used a self-reporting assessment to measure the severity of emetophobia symptoms, pre-treatment, during treatment, post-treatment, and during a 1-year follow-up. Specific phobia of vomiting, known as emetophobia, is an understudied and misunderstood phobia despite it having an estimated prevalence of 2% in men and 7% in women. Emetophobia is considered to be a chronic issue with the onset in early childhood. It often produces a clinically significant distress and impairment. The purpose of this intervention is using exposure therapy to significantly reduce the severity of Rachel's emetophobia symptoms. The goal of this intervention is that Rachel's symptoms, as measured by using the ASI-3 and the SPOVI, will reduce from her baseline measurement after receiving 5 sessions of exposure therapy. I believe this intervention will be successful because exposure therapy has been proven to be an effective treatment in the treatment of phobias. This study will use exposure therapy to reduce the severity of Rachel's emetophobia symptoms as measured by the ASI-3 and the SPOVI. Data in the study will be measured numerically. It is possible to measure Rachel's symptoms using the ASI-3 and the SPOVI assessment tool to determine the effectiveness of treatment in question. With the ABA design, the ASI-3 and SPOVI measurements will be taken before, during, and after treatment. Rachel's baseline data is collected at her intake session. Data will then be collected before each session, at the end of treatment, and at a 1-year follow-up. Rachel described her primary concerns are anxiety and frequent panic attacks. After experiencing a severe panic attack, she decided to seek medical attention. Soon after the interview began, she indicated a strong fear of vomiting. Rachel also indicated experiencing intrusive images and thoughts surrounding vomit. She said she had these thoughts all the time, and not just when encountering vomit stimuli, such as seeing or hearing others vomit. Stated that she has not vomited since 5th grade, and it was a traumatic experience. Since then, she has had continuous rumination about this experience, and she has been unable to get these thoughts out of her head. Rachel indicated that this concern became clinically significant after a situation with a family member that resulted in her not being supportive of them when they were sick. She stated that the month before coming into treatment, her roommate was also sick, and she reported having frequent panic attacks during this time. She also stated that much of her daily routine revolved around avoidance of these activities or places she associated with vomit, including drinking alcohol, public transportation, and cooking with raw meat. On the rare occasion she participated in any of these activities, she reported increased anxiety and panic attacks. Rachel also reported that she previously sought treatment for her emetophobia, but there was no alleviation of her symptoms. The primary focus of the study is to determine if exposure therapy is effective in the treatment of emetophobia. I hypothesize that the participation in 5 sessions of evidence-based exposure therapy will significantly reduce the severity of emetophobia symptoms in Rachel. Exposure therapy is an evidence-based treatment approach for people who have specific phobias. I will be using an ABA single subject design. ABA is a 3-phase design. Each measurement will be taken using the ASI-3 and the SPOVI to measure severity of emetophobia symptoms in Rachel. The first phase determines a baseline. This will consist of 2 measurements taken at Rachel's intake session. The second phase is the intervention stage and will consist of measurements being taken before each session of exposure therapy. The last phase, the third phase, measurement will be taken 1 year after the withdrawal of treatment to determine a new baseline. Strengths of an ABA design include flexibility in the implementation of the intervention, and it can be tailored to the individual subject. Patterns of change can easily be assessed and viewed. Limitations include lack of generalizing results to other subjects. Just because one study was effective does not mean another similar study with a different participant will also be. Exposure therapy is an evidence-based treatment approach to help people confront their fears in hopes of removing them from their lives. When people fear something, they tend to avoid the feared activities or situations. While avoidance can help short-term, long-term it can strengthen the fear, making the phobia worse. Exposure therapy can break the pattern of avoidance and fear. Despite its effectiveness, only a small number of people are treated with this approach. There are a few different types of exposure therapy. Graded exposure begins addressing milder feared stimuli, followed by more strongly feared stimuli. On the other hand, flooding is when strongest feared stimuli is addressed from the beginning of treatment. In vivo is real-life exposure to feared stimuli. And imaginary uses virtual feared stimuli. Some benefits exposure therapy offers include habituation, over time reactions to feared activities decrease, extinction, this weakens previous associations between feared activities and bad outcomes, self-efficacy, this shows the client that they have the ability to confront their fears, and emotional processing. Clients can learn new realistic beliefs about feared activities and become more comfortable with the experience of fear. The use of exposure therapy for treatment of specific phobias has a high level of support, and from the research done on emetophobia patients, they would likely respond to the same exposure-based treatment approach known to work in general phobias. Mack utilized this exposure-based treatment in an adult woman with emetophobia. The researchers reported that the patient showed significant symptom reduction after engaging in exposure exercises that included viewing her therapist vomit, inducing her own gag response, and causing herself to vomit. I chose to use exposure therapy for my intervention because exposure therapy could significantly reduce an individual's anxiety symptoms, increase a person's ability or willingness to approach uncomfortable situations, and strengthen learning that individuals can handle hard things. Exposure therapy works to address challenges so that you can realize that your anxiety will naturally fade over time when facing an uncomfortable or scary situation, and that you can handle that anxiety that comes with it. challenges with exposure therapy include some symptoms may return. Some patients may see their symptoms return over time. This is especially likely if the treatment is ended prematurely. Simulated conditions also always don't reflect reality. The conditions in exposure therapy do not always reflect reality, so someone with PTSD, for instance, may be able to handle simulated conditions in a therapist's office, but may not be able to handle or cope with the situation if it presents itself in real life. This intervention will consist of 5 biweekly sessions. Baseline measurements will be taken at Rachel's intake session, as well as pre, during, post, and 1 year after treatment. Post-intervention / follow-up measurements will be determined new baseline taken every week and 1 year after the withdrawal of treatment. Rachel agrees that the purpose of this exposure therapy intervention is to reduce the severity of her emetophobia symptoms. This will be measured by using the ASI-3 and the SPOVI, which will be scored by a licensed trained clinician. Testing will happen before treatment to establish a baseline, before each session, post-intervention, and during a 1 year follow-up to determine a new baseline. The Anxiety Sensitivity Index 3 is an 18-item measure constructed to assess an individual's fear of arousal-related sensations that arise from the fear that these sensations may have adverse effects. The ASI-3 measures 3 theoretically derived facets of anxiety sensitivity. These concerns include physical concerns, cognitive concerns, and social concerns. Items are scaled on a 5-point Likert type scale from 0 to 4. For the ASI-3, Rachel reported that she answered the questions related to her experience when thinking about vomit. The Anxiety Sensitivity Index 3 is an 18-item measure constructed to assess an individual's fear of arousal-related sensations that arise from the fear that these sensations may have adverse effects. The ASI-3 measures 3 theoretically derived facets of anxiety sensitivity. These concerns include physical concerns, cognitive concerns, and social concerns. Items are scaled on a 5-point Likert type scale from 0 to 4. For the ASI-3, Rachel reported that she answered the questions related to her experience when thinking about vomit. Specific Phobia of Vomiting Inventory, SPOVI, is a 14-item self-report measure of vomit phobia over the course of the past week. Total scores range from 0 to 56, with higher scores reflecting a greater severity of symptoms. A cutoff score of 10 is considered a positive screen of emetophobia. Each item is rated on a Likert type scale from 0 to 4. The SPOVI consists of 2 subscales, one by avoidance and the other by threat monitoring. The SPOVI was administered prior to the first session and every session thereafter to assess changes of emetophobia symptoms. The SPOVI was found to have good reliability and validity in the measurement of the phobia of vomiting. The scale has a 2-factor structure, with one factor characterized by avoidance symptoms and a second factor comprised of threat monitoring. It is sensitive to change during treatment. Both internal consistency and retest reliability are high. Rachel will participate in 5 biweekly sessions for emetophobia. Exposure therapy will be used to treat the emetophobia. An ABA single subject design will be utilized for this treatment. A signifies a baseline, B signifies treatment, and A signifies the second baseline taken 1 year after the withdrawal of treatment.
During the course of treatment, a trained licensed clinician will be there with Rachel during each session to provide the treatment. During session 1, Rachel will watch vomiting scenes on the computer. During session 2, she will eat feared foods in a public place with her clinician. During session 3, she will engage in fake vomiting. During session 4, she will watch her therapist vomit in real life. And during session 5, Rachel herself will partake in vomiting after she acknowledged that that is the only real way to officially overcome her fear. At the baseline, a licensed trained clinician will complete the ASI-3 and the SPOVI with Rachel. This will occur 2 weeks prior to the start of the intervention. Rachel will retake each assessment at the beginning of each exposure therapy session to measure the severity of her emetophobia symptoms. During the treatment phase, Rachel will participate in treatment once every 2 weeks, during which an exposure therapy intervention will be used. At the end of treatment session number 5, treatment will be completed and withdrawn from Rachel. 1 year after the withdrawal of treatment, Rachel will retake both assessment measures. As you can see from the chart here, Rachel's baseline score for both tests were pretty significantly high. During the intervention, as Rachel took the test before each session, both scores began to decrease. By the end of treatment and the 1-year follow-up, Rachel's scores for both tests were 0. Even though this type of treatment is successful, it relies heavily on exposure to vomit. This can present a challenge in choosing appropriate graded exposures due to medical and hygiene conditions. While an individual with a fear of flying may work up to flying safely, it has been argued that inducing vomit or one's gag response is potentially unethical and lead to unintended health consequences. Consent was given prior to treatment. Treatment and response variables change together, and there are no outside factors that can explain the results of the study. The same tests were used to measure Rachel's progress throughout the treatment, and testing was always taken before the session to measure her anxieties before treatment began. This presentation outlines the assessment and course of exposure therapy for a 22-year-old presenting with emetophobia. Based on the observed change in symptoms and behaviors, it is promising that exposure therapy is effective in the treatment of phobic disorder. Results from the study demonstrated that exposure therapy not only eliminated her avoidance of feared situations, but also a cognitive change in her reduction of hypervigilance. In summary, the case presented provide support for the continued use of exposure therapy as an effective treatment, with gains maintained at a 1-year follow-up. Additionally, it can be said that emetophobia continues to be an under-researched and undertreated specific phobia, and in order to have a better understanding of this disorder, more research studies need to be done.